All right, we'll get started. Nice to see everybody online, and then we got a bunch of people in the room as well. It's our pleasure to have Dr. Slessarev, one of our intensivists who works at UH and VH, present today on NRP, which is an exciting new development in the world of organ donation, has implications across multiple programs here at LHSC. So Dr. Slessarev is our regional medical lead for Trillium. He is an innovator, a researcher, and very good at martial arts as well as rugby. So hopefully he'll touch on all of those topics, but I will pass off the microphone to Dr. Slessarev. This session is being recorded. If folks want to see this afterwards, we'll post it on YouTube and through the Critical Care Western Twitter. And then, yeah, if folks have questions online, if you want to just type them in, I will read them out, and then we can try and have some discussion afterwards. So I'll pass off the microphone to Dr. Slessarev.
Thanks for that kind introduction, and I will preface by saying I'm not good at either of those things. So, thank you for having me today. It actually gives me great pleasure to present on behalf of a very large team that was actually started by Anton Skera here at LHSC. He's a transplant liver surgeon and has expanded to include folks across multiple institutions in Ontario, including Ontario Health. So what I'll be speaking about today is something called abdominal normothermic regional perfusion, which is a donor intervention technique aimed at improving the quality of organs after death determination, but prior to transplantation. And to start us off, these are the objectives that we have. We're going to talk about what is NRP, how it helps donation and transplantation, why we're doing this study here at LHSC and what it involves, and what is the role of the ICU team in this study. So we'll start off with the first thing here. What is NRP and how it helps donation and transplantation? So for those of you who may not be aware, there's two pathways for deceased organ donation. I don't know how to get rid of no October here. Okay. So the first, there's two pathways to deceased organ donation. The first one is known as donation after death determination using neurologic criteria. It's a mouthful, but essentially it's a donation after brain death. And the second one is a donation after death determination using circulatory criteria. You can see that there used to be known by acronyms NDD and DCD formally, but we've just had published new set of Canadian guidelines on organ donation, and the acronyms have changed just to confuse everybody. So NDD is now known as DNC, and what was known as DCD is known as DCC, and we'll have a little test at the end to make sure you guys all remember what this means. In terms of what this slide illustrates is that you can see that donation and deceased donation always occurs after death determination. So death determination is that line in the sand that has to occur before any organ recovery takes place. And that is known as the dead donor rule. It's the ethical, legal policy concept that ensures that donation does not lead to patient's death, right? And organ recovery does not lead to patient's death. So in neurologic determination of death or in brain death pathway, what happens is that patients sustain severe brain injury and then they appear to meet the criteria, and then we perform a series of clinical tests and sometimes ancillary imaging to confirm permanent irreversible cessation of brain function. Death is determined, and then we approach the family for consent. There's a workup, and then organ recovery happens after that point in time. Importantly, though, during this entire period, the patient's heart is still beating. They're supported by the ventilator, and so they're receiving oxygenated blood to their vital organs. So the organs are supported with oxygen and nutrients during this entire process up until the time of their recovery in the operating room. However, brain death is a rare event. It's less than 1% of death. And a lot of our patients do not meet the strict criteria for brain death. They would have some residual brain function, or they may have other forms of severe critical illness that may not necessarily involve the brain. And most recently, patients who undergo medical assistance and dying, they have completely preserved brain function. And so their new pathway for donation was developed in 2006 in Canada, and that was called donation after circulatory determination of death. And in contrast to to the brain death criteria, what happens here is that patients with poor prognosis have a family meeting, and there is a decision to withdraw life-sustaining measures. Once that decision is met, there is an approach for consent for donation. There is workup for donation opportunity, and if organs are suitable, there is a planned withdrawal of life-sustaining measures, and then the normal dying process occurs. This process ends when circulatory arrest happens. Then there is a 5-minute observation period to confirm permanence of circulatory arrest, meaning that circulation will not restart by itself. And after the 5-minute period, if there is no resumption of circulation, death is determined and the patient is taken to the operating room for organ recovery. The big difference between these two processes, however, is that once life-sustaining measures are removed in the ICU and the dying process ensues, there is ischemia and hypoxia sustained by the organs because there is no, the blood pressure is falling, the oxygen levels are falling, and at some point the heart stops and there's no more circulation. So the organs are suffering ischemic and hypoxic injury. And the consequence, of course, of this is that not all organs will be suitable for transplantation. So we have fewer patients qualifying as donors, and the recovered organs tend to be inferior quality than organs that come from brain dead donors because they've sustained that injury. So how bad is that injury? Well, this is a comparison of organs recovered from donation after circulatory termination of death versus brain dead donors. And you can see that for the abdominal organs, kidney, liver, and pancreas, there is both early and late complications as a result of this process. So with kidneys, you have increased risk of primary non-function, delayed graft function, 1-year graft loss, and increased risk of death. Liver is exceptionally sensitive to ischemia, and a lot of patients will suffer from biliary complication, and especially this concept called ischemic cholangiopathy, which leads to graft loss at 1 year and worse outcomes at a later time. And of course, the pancreas is the same. So the question is, what if you could reverse ischemic organ injury and donation after circulatory death by circulating oxygenated blood only to the abdominal organs after death determination has happened, but prior to organ recovery? In principle, this is essentially ECMO for abdominal organs after circulation has stopped, but before organ recovery happens. And this is known as normothermic because it's normal temperature, regional perfusion to a specific region of the body. And we've specified that region as being abdominal. There's something called thoracoabdominal ANRP, which involves thorax and abdomen and includes perfusion to the lung and hearts, but we're not going to do that just yet, and I'll explain in a second why. So how do you actually do NRP? Well, you need two things. You need an extracorporeal pump and oxygenator, so basically ECMO circuit that gets connected to the abdomen. And then you need surgical safeguards to limit the circulation to the abdomen, which include ligation and clamps as depicted in this picture. So, one across the aorta, the cava. And there is a venting mechanism inserted into the ascending aorta to essentially make sure if there's any blood coming back through collateral circulation, that it doesn't start to perfuse the brain. It's decompressing the circuit above that clamp. And by having that inserted there, you can actually see if there's any blood coming back from collateral circulation. So ANRP benefits are multiple for multiple different stakeholders. Obviously, for patients who become donors and their families, there is an increased chance of fulfilling their wish to donate and incorporate donation as part of the end-of-life care. It expands the opportunity to donate for older or marginal donors who would otherwise be excluded from donation after circulatory death. The transplant recipients, they're getting better quality organs and will have increased number of organs. And every every day there is patients dying on a wait list because of shortage of transplantable organs in Canada and the world. And for the healthcare system, we're going to look at very big cost savings from increasing potential donors and transforming into the actual donors. For those of you who have experienced DCD, or donation after circulatory death, it's a lot of times when either we mobilize the team, we mobilize the OR, there's recovery teams arriving from other institutions, we proceed with withdrawal of life-saving measures, and then the patient doesn't die in time. The organs are deemed not suitable, either because the dying process takes too long, or they take him to the operating room, and then in the operating room, they'll look at the organ and they sustain too much injury and it's declined. So there's a lot of waste in the for the healthcare system. There's obviously cost savings from cure for organ failure patients as well. So is ANRP used anywhere else? You bet. So it's widely practiced in Europe, Spain, France, UK, and most recently in the United States. And in Spain, it has actually become the standard of care for recovering livers after circulatory death. You can see in this top graph here, in dark blue is your standard rapid recovery method, where they would rush the donor to the operating room and take out the liver as quick as possible, put in a nice, versus ANRP in light blue. And you can see that by 2016, ANRP starts to take over in the number of procedures performed, and by today, almost all of their livers are done using ANRP. And the use of ANRP is associated with greater patient survival, recipient survival, and graft survival. And Spain also recently won the World Cup. So they're just champions and everything. In terms of other organs, you can see that when we use NRP compared to usual cold perfusion, there is less allograft dysfunction, and most importantly, ischemic cholangiopathy. That's feared complication in liver transplantation. And when we look at how does NRP for kidneys compare to kidneys that are recovered from brain dead donors, you can see that the outcomes are essentially the same, right? So we are making, but using NRP, the organs that would be inferior are actually becoming as comparable to the organs recovered from brain dead donors. It also has a huge impact on organ utilization. So this is, you can see the three graphs there. A is for livers, B is for kidneys, and C is for pancreas. You can see on the left side, the bar is for donation after brain death. Then you have your usual donation after circulatory death. There's worse utilization of organs. And then if you introduce NRP, you can see that your utilization becomes comparable to that after brain death. And in the context of kidneys, it can actually become better in some cases. I don't know how that is possible, but there it is. So the question is, why don't we just go ahead and do ANRP in Canada? Like, what are we waiting for, right? Yeah. Dr. Leeper, just go, right? So there's really three issues, and some of them, and they're very well outlined in this article that John authored. And really, there were three issues. The first one has to do with death determination. So we've declared somebody dead because their circulation has stopped. And in the old guidelines, in 2006 guidelines, we said that circulation stopping was permanent event. It will not be restarted. Yet 5 minutes later, after it stopped, we're cannulating this patient and restarting circulation inside the patient. Now, it's regional circulation, but it's still restarting circulation. So we're directly violating our own death determination. And that was a huge issue. And that was written in the guidelines. And our law states that we should just, it's up to the medical practice, up to the guidelines, how we practice. In the States, it's even worse, because in the States, death determination after circulatory death is actually written into law. And they've been practicing NRP there without considering what impact it may have on the law, and they have a huge problem there now. So We'll talk about it offline a little bit later, but I was just at the conference, and suffice to say, it may cause a lot of problems in the States. So we needed to resolve that first issue. The second one, we didn't know there's a lot of ethical and legal issues obviously arise, and practical issues that arise as a result of introducing NRP, and we didn't know what stakeholders' perspective was with respect to this. And the stakeholders include donor families, us on the donation side, so intensivists, nurses, RTs, and so on, social workers, and of course, in perioperative settings, you have OR nurses, and you have on the recipient side, obviously, the transplant recipients and the physicians taking care of them. So we need to understand what the implication was on stakeholders. And most importantly, the last thing we needed to resolve is how do we know that the surgical safeguards that are employed are actually effective at doing what they're supposed to do? How do we know that when you start ECMO, regional ECMO circuit in somebody's abdomen, there is no collateral perfusion of the brain? And if you resume blood flow to the brain, there's a risk, of course, of resumption of brain activity, function, and potentially sentience, and donor experiencing harm. So this was a big concern that was not resolved in that, and until we started to think about this. So all of those three issues were sort of the things that made Canada pause, and Ontario, being the largest ODO in Canada, sort of took this on as a project. And so John outlined a lot of these arguments really well in the paper, and we came up with the following plan. We said, we're going to start with A-NRP first before we do thoracoabdominal NRP, because in thoracoabdominal NRP, in theory, you have higher risk of collateral circulation. And another thing is the heart starts beating on its own to the point where you can turn off the ECMO circuit. And now the heart is circulating the blood, oxygenated blood. And the issue arising there, of course, is if the heart's beating and we detect there's perfusion of the brain, what do? Do you stop the heart? Is that, it's like, it was complex. We say, let's not think about it to start with. Let's just focus on abdominal NRP first. And the second thing that happened, we just completed guideline development that were just published in Canadian Journal of Anesthesia, the special issue. If those who want to read, there's the big guideline and 23 supporting papers. The most important change that the guideline made, it defined death as cessation of brain function, which can occur as a result of two processes: either irreversible injury to the brain, which is your brain death, or as a result of permanent cessation of circulation to the brain that can occur as a result of systemic circulation stopping. Because of that clarification, we're now okay to restart regional circulation in the abdomen after death determination, as long as we can ensure that brain circulation does not restart if we have those safeguards preventing resumption of brain circulation. It sounds like a lot of semantics, but that was very critical for us to proceed legally in Canada with use of ANRP. So that's done. That's check mark. We also had we combined forces with Charles Weyer and Nick Murphy from the philosophy department, and also Laura Lingard from CIRI, to do a qualitative study of stakeholders. And we interviewed donor families, we interviewed donation physicians, we interviewed intensivists, we interviewed transplant recipients, transplant surgeons, so on, to understand what is the impact of implementing NRP on trust in the organ donation system. Is this because we had all of these worries, and this work is now completed, and it was actually quite reassuring. I can tell you that the publication is in preparation, but I can tell you that what we learn is that the trust is not formed at the time of NRP. Trust is formed upstream when the patients first arrive in the ICU, and trust is formed by our team getting the patient to the point where they believe and they trust us that their loved one's condition is not reversible and cannot get them back to the quality of life that would be acceptable to them. What happens downstream of that is important, but not critical, essentially. So that was a very interesting thing. The plans are now to expand it obviously to the whole of Canada, but we've checked off all of those three check boxes. And so the last thing that we're going to be starting here, and this is what this study is about, is a neuromonitoring study to confirm that surgical safeguards are effective at preventing brain reanimation during NRP. So I already spoke about this. Why, like, what's the risk of reanimation during NRP? Well, if you restart regional circulation with a circuit, and there's a failure of surgical safeguard or collateral blood flow to the brain, you can get brain activity, brain function, and donor sentience, which is not something we want to have. And people say, well, come on, this patient's already unconscious. But then you start to think about MAID patients who have completely normal brain function, and who may be for whom ANRP may be an opportunity to donate as well. So we got to be very careful here. So our research question is, in DCD donors, which is our population, does postmortem resumption of regional circulation with NRP result in resumption of brain blood flow or activity? This will be a prospective observational study. We're doing it at, for now, 2 donation sites, University Hospital and Toronto Western Hospital. I can tell you we're starting way ahead of Toronto Western Hospital, so we're probably going to be the first, and we may be by 6 months or maybe even more. And we may be adding Victoria Hospital as well as a donation site. We just thought we'll start in one place first, get our ducks in a row. And even if we start at Victoria, we may be looking at potentially transferring patients for withdrawal here. Transplant programs involve LHSC and UHN. We will be including DCD eligible donors per current program criteria. We'll be excluding MAID patients and patients who have injuries that will preclude neuromonitoring. We're looking to enroll 20-30 patients over 12 months across our sites, and we will be starting in the fall. This is what the study procedures will look like. You guys may recognize some of the new part study procedures here, but essentially, after obtaining consent for donation and prior to starting withdrawal of life-sustaining measures, we'll be applying neuromonitors, and we'll be primarily using TCD and EEG in these patients. We'll start withdrawal of life-sustaining measures, then there'll be circulatory arrest, 5-minute observation period, death determination as per our usual practice. And then the patient will be moved to the operating room where the surgeons will cannulate the patients, will apply the cannulas. There'll be central cannulation and the clamps will be applied. During this moving the patient, we'll disconnect the leads from the monitors, but they'll stay in the head. And when they arrive in the OR, we'll reconnect it back to the equipment. And then when we're reconnected, the perfusion pump will start. And we'll be in the operating room somewhere between 1 to 2 hours, observing the organs. Well, the surgeons are looking at the organs, while neuromonitoring team and donation physician, either myself or John, will be there as basically the person who will say stop in case we detect something, because we don't want to leave our neurological colleagues in charge of trying to stop events in the operating room. So, Tennille Goffin and Derek Dubicki will be in the room during this entire time, observing the monitors to make sure that there is no, because we need real-time interpretation of what we're seeing to make sure there's no resumption. At the conclusion of NRP process, the neuromonitoring will stop and organ recovery will happen just the same way we do it with essentially donation up to brain death. It'll be careful dissection and excision of organs. And so this is the idea, all right? And then one thing is, what happens if we detect brain blood flow or activity? We've developed this chart collaboratively. So either we detect brain activity or blood flow, or we have unresolvable failure of neuromonitoring equipment. The TCD machine falls, drops, and breaks or whatever. Unlikely, but possible. The NRP pump will be stopped. If there is detected brain activity, we'll also wait for brain activity to disappear, and then rapid recovery process will start. So in order for us to actually realize this, we'll be starting high fidelity simulation that will enroll neurologically deceased donors who are not eligible to donate their organs, but are registered donors and would like to participate in medical education. And essentially, the purpose of this simulation is to ensure that we iron out this process and no transplantable organs are jeopardized during the study itself, right? So we're looking to do 2 or 3 simulations using these donors who declared dead using neurologic criteria. And the education consent will be obtained from donor families by the study team. So what is the role of ICU team in the ANRP study? Just continue to refer immediately dying patients to TGLN as per our gift plus criteria trigger. The consent for donation and DCD workup will still be done by TGLN and critical care team. The time will be set for withdrawal as per usual practice, and obviously we'll have to involve the OR. And the withdrawal of life-saving measures will be done by the critical care team as per standard practice, either in the ICU or in our ante room. And this is something that perhaps we need to discuss with the consulting group, because a question came up. This study will be a lot easier if we can actually withdraw in the operating room. And some centers do that because that avoids moving the patient from the ante room and losing the connections. So this is something we can discuss afterwards. What will be different? Well, the study consent from donor family will be obtained by the study team, which will include myself, John, and the research coordinator working with us. One thing I didn't tell you, as part of this Ontario working group, we had a whole education and ethics subgroup that worked with donor families to develop the consent form and to develop visual aids, pamphlets, videos, and so on to explain the process to them. It was actually a very interesting experience. It was the first one for me, and we came in with all these preconceived complexities and trying to explain a lot of stuff. And the donor families really just said, hey guys, like this is too much. Let's tone this down a lot. And it helped our ethics, our REB as well to learn that the families wanted a straight message and very clear visual aids. So a lot of these things have been developed during the months leading up to the study. The application of neuromotions will be done by the study team prior to withdrawal of life-saving measures. Now, obviously, it's a donation case, so we'll have an OR book, we'll have an OR time, so we'll know we're going to do withdrawal at 2 p.m. on a Thursday. We're not going to show up at like 1:45 trying to set up monitors. A lot of these things will be coordinated ahead of time. And the other thing is to care to maintain your probes in place during transfer to the OR after death determination, but this may not be an issue if we can negotiate withdrawals in the actual operating room. Again, how we'll continue usual end-of-life care, collaborate with the study team, TGLN facilitate study procedures, just making sure we have enough time and heads up to put the monitors on. If you have any questions, please ask. And if there are any questions, we have research coordinator. Her name is Crystal Endelash. She's part of the multi-organ transplant team who has been doing a tremendous amount of work to coordinate this. And obviously myself and John are here to answer your questions. It took a huge team, and this is not everybody, but the majority of people here, and you can see it's across both TGLN, UHN, and LHSC, and includes physicians, nurses, organ recovery specialists, and you have ethicists and so on. So it is a really big team effort to get to this point. And on that note, I'll stop and I'll take any questions. Thank you. Yep.
So I guess Anton's gonna do the cannulation and stuff.
Correct. Yeah.
And then you showed actually there are 10 questions. Like the occlusion of the aorta and venting the right heart, that all be done with catheters and balloons, like balloon in the aorta from below.
So we're going to be using a clamp. Some jurisdictions have used balloons to do it. So in order to use the balloon, some centers have introduced cannulas before withdrawal of life-saving measures. Yeah. However, that is a premortem intervention that was going to complicate things. So we said to start, we'll just use a clamp.
So Anton's going to cannulate post death.
Correct. So it'll be like an ECMO cannulation, yeah. So it's not that we're never gonna do this ahead of time,
Isn't that slower than just opening the belly and pulling an IV?
but no, it's not, yeah.
It's very-
I like, you can chat to Anton, and Marcus Elson is the other transplant
Yeah.
person involved. The issue with the balloon was it's a pre-mortem intervention
Yeah,
that does not benefit the donor.
Right.
So
Yeah.
ethically, it becomes a more complex thing to negotiate, because you have to have a prior consent, and we wanted to minimize the amount of information that we feed to families ahead of time. So we felt that that would be an easier thing to address in phase 2 of this, once the neuro monitoring piece was addressed. But
Right.
great
So
question.
You would see pre-mortem intervention like cannulation being a possibility down the road.
100%, yeah. Well, 100%, but yeah, that's it's in the plan to do that. But and that was initially what we're going to do, and then we said, okay, well, let's deconstruct this to make it as simple as possible. It's not simple,
Yeah.
but that added additional complexity, that to explain that to the ethics boards and to get consent from families. The family said, just if you don't have to do it, if it doesn't make a difference, because remember, we're going to go on pump for an hour to 2 hours. So, you know, that extra whatever minute to cannulate is
Yeah.
not a minute, but like, you know,
Too bad.
5 minutes, yeah. Okay. Good, Basu.
Two questions.
Yeah.
Unrelated. So in France and Spain, they've been doing the regional perfusion, but has anybody looked before, like animal studies, anything to know if there's any collateral circulation or any reanimation of the brain in any way? Has that been examined? I apologize, I missed the first time.
No, so great question. I don't have the slides in this slide deck, but I have several slides on that. So nobody looked at that until there was a joint UK-Canada conference on DCD hearts using normothermic regional perfusion here in Canada. And UK group was doing this for a while at Papworth Hospital in Cambridge, and they've done a bunch of DCD hearts. And they came down here, and when we came up, what about, how do you know that there is no perfusion? What about collateral circulation? And the intensivist says, well, we tie off the vessels, the great arch vessels, when we do the thoraco-abdominal NRP. And the surgeon's like, that's not why we tie it off. We tie it off to, you know, maintain our volume of circulatory volume to the organs. So the donation specialists and surgeons couldn't agree. But then when this was raised at our meeting, UK actually put the A-NRP program on hold completely for now. So it's not being done in the United Kingdom, because they wanted to investigate this. And so after that meeting, there was a study done in pigs that were randomized to clamping versus not clamping. And so if you don't clamp the blood vessels, guess what happens? There's a resumption of circulation, activity, and function, confirmed with evoked potentials. But if you do clamp, it's effective in preventing circulation to the brain. Now, the issue in pigs is the anatomy can be different, and there is obviously, you know, variance and so on in humans. Since we started to talk about this, and, you know, we've been presenting this at conferences and so on, folks started to study this. So I know in Spain, they've inserted intra-arterial catheters into carotid artery and up to measure blood pressures in the circle of Willis pre-mortem. So that study's under review right now, but I've seen pictures of it, and so far it's supportive that there is no circulation. In UK, they're doing a study, I know. In the States, they've done case report of 2, and they said it's good. So, you know, so evidence is emerging, and now we were supposed to be the first out of the gates to be at LHSC. We've been talking about this since 2017 or 18, something like that. But unfortunately, because of the little pandemic, we got delayed. So we're just getting to this. So I think what will happen is we'll develop some evidence, and there'll be evidence emerging, so we'll be collating that evidence.
I think that's helpful, actually, that there's evidence from more than just one place, that like people are looking at this and done in animals and humans.
Right. And it's one of these things where you say, well, how can you prove a never event? And that's not possible, right? Statistically, you can't prove that something will never happen. You'll have to study infinite number of patients. But in the absence of studying everyone, we said, okay, well, let's study some, and we'll have evidence emerging from other jurisdictions. And then we can hopefully be reassured as stakeholders in this, that this is a safe process. The challenge, of course, is, and in Canada, I think we're proceeding in this cautious manner is the right way to go, because in the United States, they just started doing it. They're doing it in San Diego. They're doing thoracoabdominal, great. I went to conference, great outcomes. Yeah, so the conference, I went to a conference in Philadelphia, and they invited me to give this talk on how we're doing this in Canada. And the surgeons, different programs from New York, San Diego, presenting great outcomes, really cool stuff. And then I gave my little talk, and then they invited Kaplan, Dr. Kaplan, who's a legal scholar who developed the Universal Organ Donation Act in the States. He's the organ donation lawyer, and a senior partner at one of the top firms, litigation firms in the United States. And he basically gave a talk saying how practicing ANRP is actually breaking federal law. Short story. And so they are taking organs out of
murder law, essentially?
Yeah, well, yeah, because in theory, they have a law that says you can't take you can't kill patients for their organs. And you confirm that they have died because of cessation of circulation. But now you've restarted circulation, but the law is still, so you broke that law. And then you took organs out of somebody who has circulation.
And I guess like in the talk.
And so, yeah, I said.
Like 50 people kids on the podium. All the guys who've been doing this, like in San Diego and other centers, were like, "Oh, now I'm going to jail."
So the all, Dr. Kaplan said, "Listen, I can't offer you personal legal advice, but I strongly suggest that you seek independent legal advice in preparation of a potential challenge to what is being done." Now, the issue there, of course, is, and everybody stands up and says, "Look, we're trying to save people down on the wait list," and nobody questions intent. There's a great article in the American Journal of Transplantation that he wrote. It's like the intent doesn't matter when you look at breaking federal stature. So, it's a tricky situation. The challenge there, and it's United States, right? So there is groups, lobby groups, and they've abandoned a lot of other medical things, like abortion's prohibited in a number of states now. So if somebody gets hold of this, the only thing saving grace right now, they're gearing up for the next presidential election. Nobody's paying attention to this, but American College of Physicians, which is the second largest organization, medical organization in the United States after American Medical Association, ACP issued a statement, a public statement, that basically saying that this is unethical and this is breaking the law. So it's out there. So it's just a matter of time. Somebody, you would love this, right? It's just a matter of time. And I said it to our colleagues from at UHM, because the surgeons like, let's go, like people are dying. And I said, listen, with all due respect, I think we better prepare. If something happens in the States, if there's a legal suit, it's not going to only impact NRP, it's going to impact DCD. Trust in this whole institution is built on trust, on public trust. And all you can see the, CNN or whatever, Fox News, doctors killing patients for their organs, Frankenstein, and so on. That's going to spill over to us. And so by following this process, we are well prepared, well suited to say, no, we actually proceeded in a careful manner. We consult with stakeholders, we consulted, we did ethical review, a legal review, we updated the guidelines. So we actually seen now, Canada is seen as leaders in how to do this in a thoughtful manner. The Spanish said, yeah, whatever, we're just gonna continue to do it.
Right, in Spain, they still do uncontrolled UCD.
Yep.
So you come in off the street, you're having a heart attack, it's not like for you, CPR, they go, it's game over and call it. And then because Spain has, you have to opt out, they check your card real quick, they say you didn't opt out, cannulate, and they cannulate you.
And then they wait for the family to come
And
in.
they put you on pump, and they park you, and they bring him in, so like, you're dead, but he's also on ECMO. And if you want, we need to orient out. And they're like, okay, cool.
Yeah.
You know, it's C. C, yeah, CTT. Exactly, that's hard.
Nova Scotia has adopted opt-out system. So we will learn. There's a leader project led by Matt Weiss and Stephen Beat from Halifax. We'll see in a bit how that's in general. What we've heard is the public is accepting of this change. And the premise there is we have an opt-in system. In other words, you have to go to a website and register as a donor, or you have to check off a box on your driver's license. And with any decisions, human nature is actually like behavioral psychology. People tend to defer complex decisions. It's just in our nature. I'll deal with that tomorrow on the weekend, and it never happens. We all know this. And so that's why. And so the behavioral psychology is just opt out, and very few people actually opt out. And so donation rates have gone up in Wales, accepted, and UK is now also an opt-out system. So we'll be learning what's happening. Canada is just behind UK usually by 5 years. So.
Well, I was just along this trust thing. I was just, that was gonna be my second question. I was listening to CBC radio last night driving home, and they were talking about the forest fires in BC and how they were having unprecedented numbers of people refusing the evacuation orders and staying home and not trusting the leadership, right? Not trusting that that's the best thing. And we saw that in COVID, right? Not trusting that you should get vaccinated. So this reporter was saying that when you're trying to introduce something new, and if there's a lack of trust, or if anything seems sideways, what happens is that the trusting people become skeptical. The skeptical people become cynical, and the cynical people become paranoid. And there's already, like at CCCF a few years ago, there was that whole debate about brain death. You remember?
Yeah.
There, Dr. Droffy was presenting like brain death doesn't exist. That's just
Made up thing, yeah.
Organs. So like, I think it's really good that you're engaging, like, fantastic, you're engaging donor families and everything, but these are the people that are really pro-donation. And are you doing anything to engage, like, the already skeptical, the already cynical kind of people?
Great questions, because Canadian Blood Services reached out and they said, hey guys, you happen to be doing stuff with ANRP, we heard, and so through Sam Shemy. And would you like, can you help us do this on a national level? And engaging engaging stakeholders in a qualitative study. Thank God we had Laura Lingard and Marriott from CIRI, because it's such a complex thing. Like any qualitative study is Ian's more complex than any randomized controlled trial, honestly. And there's so much work, and so we just didn't have the resources to take on public consultation. I know Kimia Honorman, who was a fellow here and clinical scholar, did and interviewed the public using Ipsos survey methods, but there's a methodological issue with asking people opinions who are not informed, right? So a better way to do is to actually inform. This is what we did during this qualitative study, where we actually developed a video to explain to them what NRP is, how it fits into the whole context. So a lot of those initial slides are actually from that material. And we then explain the issues that are raised by this. And then the participants were informed, so they can comment in a more informed manner on where they sit in this process. So our goal now is with Canadian Blood Services, if they support us with basically research coordinator assistant who can do this work and some funding, we will engage with the public as well, do exactly that. And that will be a very interesting concept, because we are operating in unprecedented times of mistrust towards healthcare in general and things of authority.
Yeah.
Yeah, so I think it'll be an interesting experiment of engaging with the public in this way, but we certainly need methodological experts, and hopefully Dr. Lingard expressed interest, so fingers crossed we can leverage that experience to engage with the public.
And my few questions are, does the cold ischemic time or the time period for which you have to wait or organs are excluded change with NRP? Are you able to wait longer? And if so, what are those times?
Don't have that data, but what anecdotally what I heard, the transplant teams are prepared to wait longer. In this case, we are enrolling all donors, so even folks who have kidney potential, and kidneys are fairly resilient. And because it's a donor safety study, even if there is no organs recovered for transplantation, but we can confirm that NRP doesn't perfuse the brain, we will still enroll the patients. But anecdotally, I've heard that it allows them to extend the warm ischemia time. So if the time was like 20 minutes for livers now, maybe longer. It also allows them to extend to more marginal donors and older donors. So 80-year-olds and so on. Not 80, but.
So question is, do you anticoagulate the ECMO, or do you want to tie enough flow data on the two? Does the anticoagulation impact?
They receive heparin ahead of time as part of DCD heparin, yeah. And so the big issue is there's a lot of bleeding around the cannulation site. And so what we've heard is they use about 3 to 4 units of blood as a result of this procedure.
But you don't anticoagulate when they're on ECMO on full flows, like you don't have.
I don't think so. No, I don't think so. Not that I haven't seen the specific products, but I mean the perfusions involved.
30K hit sort of off, pretty slick.
Yeah, I think they bleed by yeah, because it's only they give heparin just before in the agonal phase, and this is done within 1 or 2 hours. They're done, right? So the heparin should still last.
And this is influence reintubation. I mean, we don't really reintubate people for oxygen.
Not for this case. So for ANRP, if there's lung potential, what will happen is the patient will get reintubated. The lung will be inflated. There's a hollow period, and then they will be just tidally ventilated until ANRP is completed, and then they will be recovered in a usual manner, and we'll pack the chest cavity with ice. Because initially it was like that will rapidly recover the lungs, but if they do that, there will be tons of bleeding, and it's just going to be a lot of volume loss for the circuit. So it was the lung team agreed to keep it in situ until. And the exciting thing, of course, the next step will be implementation of thoracoabdominal NRP if all goes well. And in that case, a potential for DCD hearts, so hearts recovered from DCD donors, which is actually historically was the first heart transplant was from a DCD donor in South Africa. But since obviously it was neurologically deceased donors, DCD hearts may happen. And if it does, from conservative estimates, it may eliminate the wait list for hearts in Canada. So it's probably the most impactful innovation in donation that has happened since introduction of DCD. So it's pretty exciting that we're actually getting here. So in process, how this is going to work, we're going to get a notification from TGLN, either myself or John. We'll screen. If you're in the unit, I'm going to come to you. It's like, Paul, we have a potential. You're okay if we approach? So we'll approach. We'll explain the study. If the family consents, then it's all hands on deck. The OR will accommodate us during working hours, hopefully. So we're not doing this at 3 in.the morning because we have Derek and Tennille who will have to be in the room to look at the monitors and interpret in real time. So
that's the routing new thing, because most of the time they don't, right? Like when we do over there,
No.
it's like we'll do it 9 o'clock on Saturday.
Yeah.
And nothing's happening.
Yeah. And we have people setting up the neuromonitor. So it's like it's a big WhatsApp group, basically. That's
Dr. Sage, the question online. How long will it take to open chest and place cannulae / start abdominal ECMO?
5 minutes.
5 minutes.
That's what I heard. That's what they're budgeting for. So that dissection is pretty quick, but the primary goal is to cannulate as quick as possible.
Are they gonna do thoracotomy quick, man, or are they gonna go in the dome?
That I'm not sure about. I think they may go thoracotomy, but Anton will know for sure. Or Ephraim, so that's one of them. So Ephraim and Anton are two people.
So add more perfusionist requirements.
Yeah, so perfusionists are required to be in the room. Obviously, for this, we've been talking to them. For now, it's it's going to be a case here, case there. Eventually, the impact of NRP on healthcare utilization will have to be examined more closely, but the organization is supportive for now. But you can imagine, like, if we're now doing twice as many transplants, DCDs, like, we'll need perfusionists, we'll need. Now, what we've heard from when I was at the conference in Philadelphia, what they said is that eventually their team just learns how to operate the circuit and don't actually need the perfusions to come out with them. So same thing as the nurse-led ECMO model, I guess, to a certain degree. So that somebody on the team learns how to operate this, and but we need to learn how to crawl before we walk, I guess. But yeah, great question. And this another thing we're going to be looking with Canadian Blood Services, what the impact is going to be on organ utilization and healthcare needs to accommodate this, because we need OR time, we need nurses, we need perfusionists, ECMOs, cannulas, that kind of stuff, right? So all right, any other questions? First case this week. No?
Topic of trust. Are you engaging with the media before this goes live?
I
don't do it.
No.
I don't know, before you get caught on the back foot.
So we're not engaging with so my experience with the media hasn't been necessarily positive. There is media has reached out. So there is a Science magazine has reached out to me and several surgeons after the Philadelphia meeting to have a special issue, not issue like, but an article about NRP and the various challenges, and have a podcast. That was as far as I was prepared to go to talk to the media, because when science works with you, they have professional journalists that actually take their time to do proper research, fact checking. It was very, very thorough. Majority of times they just want something for the 6 o'clock news, and you don't want to like the jeopardizing this process is not. We're not there yet, I think.
If they want clicks, they're gonna broadcast that to like conservative sections of the internet to produce outrage. So like, that's gonna happen eventually. I think you'd rather have your like proof of no brain function, like to go back at them with when that inevitably comes your way.
Yeah, and
I obviously get it.
And I think media can we'll be working with ODOs like TGLN and LHSC media offices to prepare proper statements as they appear. But I think, and that's why there's a lot of work. So in the guidelines that just came out, there's a paper about postmortem interventions that we discuss, and there's 3 ideas there, one of which is NRP. So laying the groundwork before we actually say anything to the media, because they will spin it for clicks.
And when you do, I totally agree that when you have your results, you're able to publish, publication being published in a medical person, that's when you'll want to see the Lawson. Lawson is a really good media person that will quarterback all of the interviews and talk about media, very good.
Yeah.
Definitely at that kind of gate, I agree, I wouldn't engage with anything until you have results.
And for me, it's been challenging, I think, because I'm wearing multiple hats. TGLN, I'm the regional medical lead and the co-chair of this working group that's coordinating the study. I'm a researcher within the research group. I'm an intensivist and donor physician, the physician here. It's I'm just you know what, do that exactly right. Let the media offices do their job work. Sorry. Oh, sorry. Dr. Naja, go ahead. All right.
No, I don't have anything to say. I'm just surprised that you say it will take 5 minutes to open up a chest and carry on with the cannulation in an anticoagulated patient. It's just sounds a little, unless you plan to go just fem.
Yeah. I'll leave it to the surgeons. That's what they said.
I think it takes 5 minutes to go from the ante room into the OR and place the patient on the table, prep him up, drapes. It takes that process itself will take 5 minutes. So my question is, why bother with all this? Do they do this in Spain, for example?
Do they do what?
Do they do normothermic regional perfusion in Spain, for example?
Yeah, they do. I show that slide. Yeah, they do it in Spain, Europe, the States. So they do that, but they haven't proven that there is no risk to brain perfusion just yet, right? So we need to prove that first before proceeding in Canada.
I think you're right, Ravi. The timing seems fishy to me. I think the key though is like get it done this way, prove the no brain perfusion stuff, and then you can go to hopefully get the pre-morbid cannulation is the way to go. That would be incredible, right? That way you could have.
So the other thing is we can explore as a consulting group separately whether we are okay to do the withdrawal in the operating room for the purposes of the study to reduce that transfer time and to reduce the risk of dislodging neuromonitor. So I'll send a separate email about that.
There you go.
Yeah, sure. Even if it takes 5-10 minutes after a period of hypoxia and ischemic injury to the brain, before the declaration of death, it takes and then after declaration of death, it takes another 5 to 10 minutes to hook up the patient and do the cannulation. In 10 minutes, the brain will have suffered irreversible ischemic injury. So I look to the results.
Yeah, most likely. I think you're most likely right, Ravi. New part study, which is enrolling patient currently in this ICU, will tell us that results hopefully soon. Okay, thanks. We'll wrap it up. Thank you, everybody.
Thanks for having us.